Today, we'll begin a simple primary care review on genital herpes infections in pregnancy. The herpes simplex virus infection is prevalent worldwide. The HSV infection during pregnancy can be transmitted to the fetus, and neonatal infection can result in serious morbidity and mortality. So, the different classifications of genital herpes is primary, where the patient has a first infection of a genital HSV lesion and no HSV antibodies. Second, the non primary first episode, where the patient has a first occurrence of a genital HSV lesion and positive for HSV antibodies. Recurrent would be the patient has a prior HSV infection and occurs in the genital lesion again, with the same type of antibodies in the serum. The clinical manifestation of the primary genital infection is that there are severely painful genital ulcers, pruritus, dysuria, fevers, tender inguinal lymphadenopathy, and a headache. The non primary first episode genital infection tends to be milder than the primary infection. Recurrent infections tend to have mild, localized symptoms with few lesions and lack systemic findings. Diagnosis would be through clinical findings of vesicular and ulcerated lesions. They should always be confirmed with either laboratory test of the HSV polymerase chain reaction test and or the HSV viral culture test from the lesion. Vertical transmission. The transmission of the herpes simplex virus from the mother to the newborn usually occurs during labor and delivery by direct contact with virus shed from infected sites. The highest risk for newborn infection occurs in women with a primary genital HSV infection acquired near the time of delivery. Treatment or management would be for the primary or non-primary first episode genital infection would be a empiric antiviral therapy while awaiting viral studies such as acyclovir 400 milligrams taken orally 3 times a day for 10 days. Treatment for the recurrent infection wouldn't be needed since most recurrent episodes are short-lived and do not require intervention. Suppression therapy. Antiviral therapy can be restarted at 36 weeks until the onset of labor for suppression. And supportive measurements would be analgesia and a sitz bath to help relieve fever, vulvar pain, dysuria, and other local symptoms. Thank you.